You're listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We'll be joined by cancer experts to discuss blood cancer diagnosis, treatment, survivorship, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. I'm Dr. Ken Miller. I'm a medical oncologist, hematologist, and a Blood Cancer United volunteer. And I want to thank all of you so much for joining us on this episode. Today we'll be discussing delivering equitable cancer care, exploring how social determinants of health, cultural competence, and communication with patients, caregivers, and healthcare professionals shape patient outcomes. We're delighted to be joined by Dr. Raymond Mailhut, who is an associate professor in the Department of Radiation Oncology at the University of Miami Cancer Center in Miami. Ray, thanks for joining us.
Thank you. It's a pleasure to be here.
What's your personal journey, if you don't mind my asking, in terms of getting into this field, and maybe not radiation, but as much as being interested in healthcare disparities and cultural competence?
Sure. So my mom is from Honduras and my father's from Michigan, and they met halfway in Alabama.
Okay.
And so I think that there's a lot of different images already when I mention Alabama and Honduras that goes into my quote unquote cultural background. In medical school, I think medical school is a time to find things that you are good at and things that attract you. And I was very attracted to the oncologic space. And really, I did my sub-I in peds hemonc, and then I really had a chance to meet a mentor in Boston in radiation oncology, which really pushed me to pursue rad onc as a career field. I will say that as time has evolved, I mentioned that I'm a radiation oncologist that treats kids. I'm the only Latino person that does that in the entire country.
Wow.
And so I think part of the reason of being in Miami is that I can be in a community where I have a large impact.
Yes.
I think seeing the influence on my own family's care when I would serve as a translator for them when I was younger influenced me too, that I can be an advocate for patients who have limited English proficiency. If it's Spanish, I am bilingual, but it is something that I'm familiar with, if not with the value of having an interpreter. I will say, if we're talking about cultural competence, one of the things I am excited to talk about is a trial was actually published about 3 years ago by a group out of UCSD that randomized patients to receive care with a physician who spoke Spanish, was deemed bilingual, versus an interpreter. And patients consistently, significantly rated bilingual physicians associated with improved satisfaction. And importantly, because I wrote a companion article about this, is the authors were not Latino. So I think a lot of times when I speak to language learners, they can be concerned with having an accent, when really mastery can be achieved at any age. And I think that trial is, for me, it's a different type of trial with a different type of outcome, but it did make me smile because it is something that anyone can do through Duolingo, through classes at home, to really better engage patients and create that bond that we were talking about earlier is something as simple as establishing a familiar language or linguistic connection between people.
In anticipating this podcast, I've been thinking a lot about equitable care and cultural competence. And one of the thoughts that went through my mind is I think there's certain myths maybe we believe in, or maybe I believe in, but one of them I say, geez, I'm delivering culturally competent care. But I wanted to get your sense, because you've been practicing for a while, you're in an academic setting, in a multicultural setting. Very broadly, how would you rate the cultural competence?
Thank you for that excellent question. So first off, I want to acknowledge that I'm a radiation oncologist, and I'm thrilled to be here on this discussion regarding treatment and cancer care for patients who have blood cancers. I think rating cultural competence for oncologists is just a key part of shared decision-making that we have with our patients. I think, speaking from a radiation perspective, when you ask a general American thinking of Family Feud, when you think of radiation, what do you think of? Most Americans are familiar with radiation, unfortunately, through accidents such as like 3 Mile Island or in the course of, let's say, World War II. And so in my discussions with patients, those items that I just mentioned do bring a lot of understandable stigma and a lot of associations, and people wondering, now I'm going to be subjected to this, either in the context of something that's related to an accident or something that was honestly a part of World War II. So, in that brief time that we do have, it is essential in order to gain trust, but also understand where someone is coming from with their understanding of whatever treatment we're talking about, be it radiotherapy, be it targeted therapy, the influx of immunotherapy and CAR T options, understanding what media, what cultures may have influenced with someone's understanding, and at the same time, building trust.
So let me ask you more about that. Even if we sort of take that down from 60,000 feet down to ground level in terms of sitting in rooms with patients, your point's very well taken that it's important to assess it. So much of it has to do with the words we use, but also the tone. How do you ask someone, a patient, a family, what's your understanding of what I just said? Because I want to do that as well as I can. How do you do it?
What I generally do is I break up my discussion in parts. So usually I start with talking about radiation in general, and then I say, I'm going to pause here. What can I answer from what we just chatted about? What can I clarify? And I think going back to med school, one of the most influential pieces of advice I received wasn't to phrase, do you have any questions? But rather, what questions do you have? To just normalize the fact that this is a discussion between physician, provider, and patient. And to normalize the fact that you're not going to get everything right the first time, I think that's unfair to assume anyone could when we've been
Right.
training for decades in this.
Yep. Yep.
So, usually starting with understanding of why are you here? Why are you meeting me today? Giving then corollaries. Most people have had an x-ray, and so that becomes an easy way to understand you probably received radiation, not necessarily therapeutically as a matter of anti-cancer treatment, but if you've gotten an x-ray, then you have experienced radiation and you know you can't see, taste, touch, smell, or hear it. Then I'll talk about the benefits, if there are any in this case for this consultation, and then specifically side effects, breaking it up into acute side effects, pausing again for a point for clarification and questions, and then at the end for late toxicity, late effects to discuss it. And then I do give an overall, what questions do you have? What can I clarify from anything we've discussed so far?
What makes for a successful connection and what makes for ones that are not successful? And I want to tell you where I'm coming from with this in terms of cultural competency. Stepping into an exam room, it's a new patient. What are some of the things that get in the way and what are some of the things that sort of close that gap so that the communication is truly effective?
I think when we as physicians begin to use very domain specific vocabulary, that can become, unfortunately and unintentionally, exclusive. So, really trying to use vocabulary that is intelligible to someone who doesn't have any medical training, which can be hard to do when we are always in tumor boards, journal clubs, reviewing constantly. It is switching a different part of your brain to be more external. How do I discuss what I do in my day to day with colleagues versus how do I discuss it in a way that's inclusive for someone who's about to put their faith in me and trust in me that they're going to say, Dr. Ray, you will be my physician, or in my case, I treat a lot of children, or you'll take care of my child, that I trust and I have enough understanding to put that faith in you.
I'll be fully disclosing. So I am a white, more than middle-aged man. So I walk in a room and I'm seeing someone who's 25 years old. And let's say everything is opposite of that. So they're younger, of let's say African American, and of very limited resources. What are some of the issues that may come up in that interaction that, again, may be different than if I'm seeing someone who's culturally and age and background closer to me?
So I think what you highlighted the most that I'm going to focus on is the age of the patient. And what
Got
we
it.
do know that patients who are adolescent young adults, so 15 to 39, are at a particularly vulnerable age group. And so it might not be things that are communicated in the room, but understanding that this is typically the time of life when people are generating their savings. This is when they're starting to get that bank account going with having a job. But they're also starting to have kids. So there's a lot of different priorities that may be at play that are not witnessed necessarily in the room. I think showing up to that clinical visit already demonstrates it's a priority, but patients and humans are rational beings. And unfortunately, sometimes taking care of a loved one, be it a child or a partner, does get prioritized, but below someone's own healthcare, even for cancer treatment. So understanding, I think in that aspect, the social history of how can I help make sure for my patients that they can get the care they need. And then I think really in shared decision making, a lot of what I focus on is Hodgkin lymphoma. If you open that NCCN, it's like a Cheesecake Factory menu. You could do pretty much anything, which
Yes.
means it's a great example for when you could really lean into shared decision making. A rational person could see that and say, you know what, I need to minimize, unfortunately, time away from work. And so that leads to a different treatment paradigm than if they're prioritizing minimization of late toxicity or just depending upon what they want. I think it really affords us an opportunity to understand how can I best support you, understanding what your priorities are, and the fact that we're a team.
If we say that our goal for our patients is for them to get the best possible care, which patients are likely to get that and which patients are less likely to get the optimal care?
That's a great question. And I think it does come down to the haves versus the have nots, and then what in our society propagates that. I think insurance status is going to be one of them. Depending upon where someone may work, that's something external to them. They might not even realize all the barriers of entry that patient did have to theoretically cross just to see them, versus, let's say, a public hospital that would accept everyone. So with insurance status, everyone listening is going to be used to the concept of prior authorizations, waiting either for treatments, waiting to get diagnostic imaging, extending treatment times, just with that unfortunate framework that is really buttressed upon the haves versus the have nots, what kind of insurance you have and how quickly can care be expedited. And am I getting, again, quote unquote, the best care, in the best meaning, honestly, standard of care.
Yeah, yeah. What do we do as providers that actually doesn't remedy that situation, may make it worse? And what could we do? When I'm sitting with a lot of my patients are, well, have nots from the point of view of very low resources, very poor insurance, all of those things. So again, what do we do that makes it worse and what can we do to make it better?
That's a good question. I think there is a lot on our plates. I'm probably preaching to the choir between writing notes, completing prior auths, teaching if you're at an academic center, conducting research. But I think completing those prior auths when they come to us, because I think the last thing we would want to do is to be a reason why someone's care is delayed. But something else that we technically are all capable of, not only as physicians, but as individuals, is becoming more active on local, state, or federal levels. I will say this past year, I've become more active as an individual, not necessarily representing my institution, but getting to know my representatives and explaining what matters are important to me. In my case, I specifically spoke about childhood cancer research, the importance of that. And I was actually introduced to my Congress folks by Blood Cancer United representatives. So they helped do that for me too.
Terrific. I hope everybody out there hears that. It's a great point. And you're right. I think we're very, very busy with just the day to day and having a personal life, but that really is a place to make an impact. Thank you. Any experiences sort of stand out in your mind of your own, you or your family or a patient, of a very poor outcome in terms of communication, or a particularly good one?
This is probably true of all patients, but as a radiation oncologist, I do have the chance to treat children and adults. So you're boarded across ages. And I will say what I notice more with families is no one ever wants to meet me, and that's fine. I get it. It is so intelligible, and I think in an ideal world, we would meet each other in a circumstance that didn't involve a child having cancer. I've had successful interactions where patients at the end of treatment have still said, and actually, as recently as 3 months ago, I remember a mother telling me, I wish I never met you, but there was nothing I would change about the care that you delivered. So I think being able to communicate, being able to have families or patients themselves feel an active part of their decision making and an active part of understanding what is being received by their body, either through an IV, orally, or externally with radiation, so that there is a level of agency in such a journey where that has really been stripped from them.
Absolutely. I have to say, as a medical oncologist, it's the same thing. No one wants to get chemotherapy, but I try to share, and it's really sharing the sense of there's two ways to get treated. One is where someone says, you know what, I don't want to do this, but I want to get better and let's do it. And the second is where someone, each time they're treated, it's such a terribly negative situation. So as much as possible, I really try to coach patients that if they're actively participating, typically it's tolerated better. And my own belief is it's more effective.
Yeah. And I think as you're describing that, this brings me back to the first point that you talked about with social determinants of health. And what got me thinking is just the fact that I'm thinking of daily treatments, and you're probably thinking of weekly, and
Yeah.
or a
Every
certain amount
three
of
weeks. Yeah.
correct.
Yeah.
And so, especially for the patients I see, transportation, which would be as important for you, but we do know that there's loss of outcomes the more that someone can't maintain that 5 days a week.
Right. Right.
And so, transportation issues particularly can manifest for the folks undergoing radiation. And so, what we especially want to avoid is someone having started treatment and then something goes awry. And in essence, delivering a treatment not halfway, but actually worse because they've started it and now you're not able to deliver it the way that you would have actually wanted to. And so I think another item that we typically think about is distance to treatment and the decisions that people will make for ease or access, again, with prioritizing what is rationally important to them. And then second to that is how close, when we think about outcomes and the fact that patients on clinical trials do better, and we want to afford patients that possibility to participate. Again, with the idea of access to treatment, access to care, how difficult is it to participate on a clinical trial? How many boxes have to be checked off? What is really necessary for a patient to be on it? And then is a clinical trial something that they can actually access if transportation is such an important need for them?
So let me just share. Excellent point, because when I really think about, we are all promoted to put patients on trials, and yet, I mean, being aware of the just day-to-day barriers is really important. I wanted to ask you about terminology a little bit. The idea of cultural competence, I mean, is a term that I've heard many times. There's also discussion in literature about cultural confidence and cultural humility. Any thoughts on those terms? Confidence and humility.
Sure. I think what all of these are getting at, and we'll talk about the differences, are underscoring is emphasizing the idea of belonging and not creating a space that is exclusive to someone. Because what we would want to avoid is in a discussion about someone's cancer treatment, accidentally saying something that could land offensively or improperly, where then in addition to just focusing on digesting what are all these things that are being discussed, these polysyllabic words, and at the same time something that could be interpreted as some type of personal slight or some type of accidentally personal offense. So I think all of these imply a certain amount of humility from the sense of the provider, that we are in a certain space throughout our training. We're not there to judge our patients with regards to their social history, with regards to their being from a background of having or have not. We're there to deliver the standard of care, and again, within what we can do, ease this journey they didn't want to be a part of to get to that finish line.
Thank you. Ray, as I look back on my career, there's patient stories that I sort of carry with me, things that I've learned from or that have broadened me as a person, as a doctor, et cetera. Any stories that you sort of carry with you?
I appreciate that question because I'm already smiling thinking of a patient. And I've actually had the chance to chat with her before on another podcast. And this is someone I had treated when she was a minor with Hodgkin lymphoma. And she was diagnosed in the panhandle of Florida. Florida is a large state, not only north to south, which people think about, but also east to west, going from Jacksonville to the southern part of Alabama. And so in that northwest corner of Florida, sometimes Birmingham can be a little closer, Birmingham, Alabama. And so she was diagnosed pretty acutely and airlifted to UAB, the Children's Hospital at Birmingham. But keep in mind, a lot of times when we think about children and young adults, one of the most common, if not the most common insurance, is going to be Medicaid or a state-based plan. And so you can go to an ER and be adequately worked up. She couldn't receive her care there. And so if we think about Birmingham being 4 to 5 hours north of where she was, her next step is 4 to 5 hours east in Gainesville. And so at that point, there had been, right now, COG and the adult cooperative groups are coming together with using ABVD in general for patients with Hodgkin lymphoma. But for a while, COG was using ABV EPC, which is an inpatient-based regimen. And so now she's moving across the state, is also missing her prom. And during her first round, she develops tophitis. And so I speak to the pediatric hemonc at Gainesville. We talk about a plan for her to be able to switch systemic treatment, which at that time, based on the regimen that was going to be utilized, consolidated radiation would be indicated. And I'm even further east in Jacksonville. So this young woman's treatment, a mid to old teenager, took her across 2 states, driving 5 hours. So to date, she'd want me to share that she had a baby.
Oh,
So she's doing really well.
that's
And
nice.
you make connections with people. But I met someone when they were at a pretty rough time. And I think just, again, with the limitations that our infrastructure creates with insurance and where you can go, to be airlifted to another state and then not get care there, that's a kick in the pants.
Yeah, it is. It really is. What are some other barriers to care and also barriers for participation in clinical trials?
I really like the clinical trials question. Most children will be enrolled on a clinical trial, but that's not what we see for adults. And I think, thankfully, pediatric cancers are rare, and the advances that we do have reflect this leaning in, where many families will say, it might not help my child, but if it helps someone else's with a similar situation, I'd want to embark on that. I think with adults, we're again dealing with rational human beings making rational choices. And if a clinical trial requires to be at an inordinate amount of visits, exams, calls, that can be somewhat prohibitive,
Yeah.
especially if someone is having a job or trying to balance any number of life priorities that they're trying to maintain at the same time. Making sure that costs, which we generally try to do, but there can be unexpected costs, something as simple as parking. But there is a good JAMA Network Open article on how parking costs affect cancer care. And again, the level of language difficulty we use when we talk about these trials, when someone reads a consent, when you get to page 50 of a consent, that's really far. That's a book. And so I think understanding and where clinical trials are evolving is not also excluding as much as possible, where when we think of, this has been within the last 5 years, but these very tight eligibilities, these very narrow child Pew score of X, or just, you want an INR of so much, but to really be inclusive, because at the end of the day, there's going to be a real world applicability and you don't want to exclude people from the chance to participate. Again, speaking of language, and then a goal of decentralization. Does everything need to be done at HQ, so quote unquote, or is there a way to make it easier to relieve some of the burden on patients in participating so that they can still receive the benefits but minimize any of those barriers?
Yeah, thank you. That's a great summary of things that make, as I'm listening to them, things that I would not necessarily have thought of, but I would have thought about the 50-page consent forms because I've seen them and I've helped patients go through them. A lot of your research is on this topic. I know you've published on proton beam, for example. Tell us a little bit about proton beam and disparities, but then more broadly, some of the other research you're doing.
Sure, I'd be happy to. So in between residency, I ended up getting a master's of public health and did a lot of work on economics and Markov modeling. And so I published a lot on establishing what would cost-effective allocation of this resource look like. And why I'm phrasing it that way is when we think of proton therapy, which is a type of radiation, the benefit that we associate it with is a reduction in late toxicity. Again, going back to Hodgkin lymphoma, a disease that initial curative radiation monotherapy was quite effective. It's very curative.
Yes.
But it's following patients for a long time that they could see the toxicities associated with those large fields using the somewhat outdated modalities. But it truly was toxic if we think about it in that terms. So the rationale behind proton therapy is X-rays are generally what we use for conventional radiation. And when I think of an X-ray, I think of kind of like a skeleton. And why that works is because neutral or non-charged particles go straight through tissue. And if you put a camera film behind someone, then the bone will develop as white because it was further attenuated. And that's the same with X-rays when you're delivering it therapeutically against a cancer. It'll be able to hit the target, but it doesn't necessarily stop at the target. And charged particles behave differently. Protons being a charged particle, the heavier or the more massive the particle, the quicker it stops. So the benefit isn't necessarily predicated on being any more effective at curing cancer, but especially when we think about children, adolescents, young adults, or tumors that might be against some type of important critical structure. Being able to reduce not only acute, but especially latent toxicity, be it cognition, heart effects, secondary breast cancers down the road. And so a lot of my initial work focused on if every American with cancer decided to have proton therapy tomorrow, they couldn't just because there's not enough centers. And so while we're waiting for long-term data to mature, because we're talking about endpoint, HD6 reported that endpoint for secondary for overall survival with Hodgkin lymphoma at 12 years. And so the first 5 or so centers went online around 2007. It's going to take a number of decades to have the long-term data to actually report on it. And so how can we best decide, especially talking to insurers, that yes, I believe that there is a rationale and a clinical rationale for this patient to receive this therapy, which is a limited resource. The research that I'm pursuing more today comes in 2 main camps. And I am very grateful to be here as a recipient of a Blood Cancer United Award, and as well as I have an R37 through the NCI, focusing on how to improve outcomes for patients from underserved backgrounds with Hodgkin lymphoma, be it from a perspective of those people who are under or uninsured or a marginalized community racially and ethnically. Could it be differential access to salvage treatments, which still today does remain myeloablative chemo and autologous stem cell transplant? Or what I find more exciting, and this is the MPI for my award is Dr. Aaron Mobley, is survivorship care. We do know that patients who are under and uninsured, especially AYAs, are more likely to forego survivorship care based on their insurance status. And that was the driving factor with the survival detriment associated with radiation and Hodgkin lymphoma treatment. Could it be that that is contributing to differential mortality in the real world? And the third aspect of these awards is shared decision making. Again, I always compare Hodgkin lymphoma treatments to a Cheesecake Factory menu because it just goes on and on and on. And our patients being afforded that opportunity, that if they wanted to have a consult go that long, that they are getting that differential understanding between, is my path for early stage Hodgkin one that involves radiation or not? Am I going to have a targeted therapy? Am I going to receive an immune checkpoint inhibitor? Or there's so many flavors of treatment and care, and understanding with this disease where disease-free survival should be in the 90%, or overall survival definitely above the 90%. A lot of this conversation should rationally focus on long-term toxicity and how much of that is getting to our patients afforded the chance to talk about that, and even the chance to talk about survivorship care.
Wow, very interesting, and maybe the topic of another podcast.
I appreciate that, yeah.
So I want to thank all of you for listening. This has been a really interesting, informative podcast. I also want to thank Dr. Ray Malhut, who is an associate professor in the Department of Radiation Oncology at the University of Miami Cancer Center. Ray, thanks so much for being with us.
Thank you. Thank you for having me.
And for a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources, please visit bloodcancerunited.org/CE. For any questions or to refer a patient to Blood Cancer United, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients understand their disease and treatment, access financial and support resources, and navigate challenges like medical debt, insurance benefits, denial of care, and out-of-pocket costs, all topics we've been talking about today, through the Medical Debt Case Management Program. I encourage you to learn also about the eligibility and criteria and refer your patients to this program. Blood Cancer United also provides other resources for patients, survivors, and their families. And you can learn more about that by going to bloodcancerunited.org/support. Finally, I encourage you to sign up to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. And if you have suggestions for future episodes, please click the feedback button on this episode page. We look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archive section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with Blood Cancer United by following us on social media and access our healthcare professional continuing education activities by visiting bloodcancerunited.org/CE. Let's keep the conversation going. Until next time.